obstructive jaundice. We just got all the jaundice done at once. They're so confusing, and it's one of those things I'm telling you, just keep going over it and over it until it sort of gels in your mind. It will help you go over it. The very last little part here about bilirubin, and then we'll do some other liver function tests, is interfering factors. There's only two that I think are important, and the first is sample hemolysis. So when you go to study for your quiz, you're going to go, well, that doesn't make sense to me. Sample hemolysis decreases your bilirubin. And why that won't make sense to you is because you think, well, hemolysis causes prehepatic jaundice, that's person hemolysis. So person hemolysis will obviously increase your bilirubin. But sample hemolysis, like a bad blood draw and lipemia, those decrease your bilirubin. So we try to avoid those. Second thing about bilirubin is it's really sensitive to light. So for in the laboratory kind of way, we protect those samples from light. In a human being, we use that knowledge to decrease somebody's bilirubin, like a baby. A baby who has jaundice is put under billy lights or billy blankets or billy coats to destroy the bilirubin. It's very sensitive. Okay. Next is normals. I don't need you to know normals because you can look those up. The measurement of bilirubin uses what's called the Vandenberg reaction, and whether it's called Vandenberg is really kind of neither here nor there, but it measures direct reacting and it measures indirect reacting. So that's just I'm vaguely familiar. So bilirubin, so it's total bilirubin, is direct plus direct, your turn, water soluble or not.
Soluble.
Yep, the water soluble stuff. Conjugated or not.
Conjugated.
It's the conjugated stuff. Yep. And the indirect then is the insoluble and the unconjugated. A lot of labs just measure total and direct. I don't know exactly why, I figure doctors know how to subtract or something like that. And then you just have to figure out the indirect all by yourself. So that's the measurement, okay? So it's direct plus indirect equals your total bilirubin. Couple of decision levels here. 1.4 is kind of at the top end. You know, for most people's labs, normal range, 1.4 is kind of the top end of normal there. Sometimes actually over by maybe 0.2 or so. So what you should do is go, wonder what can do that? And you should rule in and out various liver diseases with doing some other liver function tests, which we'll talk about in a second here. 2.5 is associated with clinical jaundice. Let me say that a couple of different ways. If you have a person who is jaundice, what would you expect their billies to be? At least, Justin?
I have a question.
Okay. I'm ready.
So, like from all the pictures yesterday, if there's a problem with direct and indirect bilirubin, that's going to be a problem with total bilirubin, right? So
Yep.
we're always going to have a problem with total bilirubin.
Yep.
So do we need to know all three values?
It's coming up with arrows, and I'll show you. Good question, that you're right. If direct goes up, total goes up. Indirect goes up, total goes up. So you're right. It's a proportional kind of a deal. And we're going to use arrows like 2 arrows and 1 arrow and stuff like that. I asked you guys a question before. Justin asked me a question back. So if a person is jaundice, what would you expect their billy to be? At least 2.5. Okay. So bilirubin of 2.5 is associated with clinical jaundice. So if you have a person whose billy is 2.5 or higher, and they're not jaundice, you need to think about what the heck's going on, right? Maybe numbers got transposed, maybe it's keratonemia. How can you tell the difference between keratonemia and jaundice? Because you can't.
Liver function?
Eyes. Shiloh, is that you? Eyes.
Sclerosis.
So keratonemia will not have yellow in the eyes, okay? But otherwise they look the same. So if somebody has 2.5, we expect jaundice, and you should again consider various things that can cause a patient to have jaundice, rule some of them in or out, doing other testing. 20 in an infant is associated with kernicterus. Kernicterus is bilirubin crosses the blood-brain barrier, which is very poorly formed in an infant and child for that matter, an adult for that matter. And in an infant, it will cause kernicterus and mental retardation. In an adult, it doesn't. In an adult, your bilirubin can go up as high as you want it to be. The highest I've seen is 29, and it's not going to cause mental retardation. But in the kiddos, 20 is a really good number to probably hang your hat on a paycheck, that it will cause kernicterus. You want me to spell that?
Yeah.
I've been teaching for 40 years. I had it ready to go. It's Kern. First of all, I'd like to take a survey. How many people would like a medical terminology course when they get here? That's what I thought. Would it not have made it a lot easier to know some roots of Latin and Greek, what words mean to well? Say that.
I took medical terminology before I started here, and I don't feel like it was helpful at all. I'm just saying, because it felt
That
like
means
a waste
yellow.
of the time.
Really?
And a waste of tuition.
You can do them online for free. I did mine through the mail 100 years ago. But the reason I say that is current means nut, or kernel like your brain, and icterus actually means yellow. So kernicterus is the deposit of bilirubin in the gray matter of your brain. In an infant, causes brain.
And you said it's greater than 20 milligrams?
Yeah, so the Kazakh said greater than 20 for sure. And the number seems to be a moving target number. And every hospital is a little different when they get wiggy about billies. So, no hospital is going to say, well, let's wait till 20 before we put that baby under lights. They're going to go, some go at 10, which seems more conservative. Some wait till 12, something like that. 18 is kind of an absolute. So, and just a second, Kate. So, if a baby's hands and feet aren't yellow, sort of a rule of thumb, you know that their billy is less than 18. 18 seems to be pretty critical, like for a billy for a baby.
So that's just in a regular newborn, not in a preemie.
Correct. Well, no, I don't want to say that. Any baby, if their billy's, that's a loaded question. Okay, we'll try it this way. Let me try it this way. If it's pathological, it's a big deal, super big deal. Physiological, they don't get as wigged out on, but a physiological of 18, I really think most babies that get put under lights, they're gonna want that to go down. And breast milk jaundice, it's a completely different word, very strange. So I don't mean to confuse you on that. It's very hospital and doctor dependent with their guidelines on treatment.
So in your notes it says greater than 15 or greater than 10 and 20. So do you just want it to go over?
That greater than 15 and greater than 10 isn't where you get kernicterus, it's where it's dangerous. Okay. So I don't care that you know those numbers. For now. All right. Big list, don't worry about it. Criticals, don't worry about it. Clinical significance won't matter to you at this point because you don't care anymore, but I'm going to write them down for you. When you go to know this stuff, which I think might be starting this weekend, you might want to start working on this. We have a quiz next Thursday on this. Work yourself through these jaundices to try and get a handle on this, okay? Right below the thing I'm going to talk about is a chart. You're free to memorize it. Your study guide for this quiz is an empty chart. The reason I give you empty charts is not to be mean. It's to make you learn. When one person fills out a chart and sends it to the rest of the class, do you know who learned?
Person that filled it
The
out.
one person who made the chart is the person that learned. The rest of you are just memorizing stuff. The reason I give you blank charts to fill out is it needs to go through your brain to figure out what goes where. If you want to memorize the chart, you can. You're probably going to get screwed up. If you go to reproduce it on the quiz, you're going to go, oh man, I don't know, is that one arrow up, is that down, is that normal? I don't remember anymore. So I think it's better to actually understand. So the stuff right before that is the clinical significance. So we got three of them, right? We got hemolytic anemia, we got hepatitis, and we've got obstruction to the flow of bile and cholestasis. So Justin is correct in that the total for all three of those is going to be increased, because that's what we're talking about, right? They all have an increase in bilirubin. Total is indirect plus direct. So I got to do it the way yours are. Yours are direct and indirect. Because I don't think, but I'll try. Let's do obstruction, because it's probably the easier of all of them. Which one do you think would go up, direct or indirect? Obstruction to the flow of bile. Direct. Direct is right. So go ahead and put 2 arrows up for that one. What happens is some of it unconjugates itself as it's floating around in your bloodstream, so you can put a little teeny tiny arrow under the indirect one. Okay? For hemolytic anemia, if you think of the picture there, that's all those red blood cells breaking down into bilirubin, which is insoluble and unconjugated, indirect, because the liver can't handle it all. The direct is generally normal. You can have a slight increase of it, you can remember it however you want. The big deal is that the indirect is like 2 arrows up for hemolytic anemia. And for hepatitis, the indirect is 2 arrows up and direct is 1 arrow up. That's that really hard one that we did yesterday as to what the deal is. And that's just the serum bilirubin. There's also the urine bilirubin and the urobilinogen, which is the chart below. It's all 4. Okay.
And that's the one with like, some of it's going to dead cells. Some of it is going to dead cells that like can't conjugate.
Correct. And then, so that's where the indirect comes from, is the dead and dying cells cannot conjugate it. And the direct comes from leakiness between the 2 junctions. Jessica?
So these were all values for serum.
This is, yeah, that little arrow thing there where it says clinical significance, that's just serum bilirubin. The chart below is serum and urine findings. So that's just a chart form of all of those pictures that we did yesterday. Zach and Kat.
So for the values for hepatic, is it normally the same for if they have acute or chronic hepatitis?
For bilirubin?
Yes.
For this serum, pretty much.
Okay.
I'm not gonna go there with you guys.
Okay.
It's just hard enough.
That's fine.
You're going too fast, Zach.
Kathy?
I'm sorry, I just couldn't understand the last indirect for obstruction, that's arrow up. It's just a little
That's, for the indirect is 1 arrow. Here. I was gonna make a little arrow, but I'll just make 1 like that. So it's twice as much direct as indirect, more or less, in about a 2-to-1 ratio. Like I say, it won't make a whole lot of sense today because it's like, we don't wanna know this. So it'll come back to you in a while. I'm going to study it. That's one liver function test. The rest of them go really nicely because we talked about just about all of them. The first thing, the next is lipids. So we talked about lipids when we did our 3rd chunk of material. And if you remember, the liver played a very large role in lipid metabolism. It was the key organ for synthesizing cholesterol. Most of your cholesterol was synthesized in the liver, and a little bit more from other tissues. When you look at diseases of the liver and lipids, with obstructive jaundice, without looking at your notes, give me a number for acute obstruction for cholesterol.
300 or 400?
Yes, 300 to 400 milligrams per deciliter. And if it's chronic obstruction,
7 to 8.
700. Little teeny tiny circle that we just finished there. Okay? So with obstructive jaundice, we expect really high levels of cholesterol because we can't get rid of it through the bile. Okay? With intrahepatic obstruction, which is sort of a key word for hepatitis, cholesterol levels go up with acute-like hepatitis. Let me walk you through this. So I just said that cholesterol was synthesized in hepatocytes, right? 2/3 of it. So kill them, hepatitis. That cholesterol that's inside that cell will be released. So we expect with early hepatitis, acute hepatitis, we expect cholesterols to go up. If you go into chronic hepatitis, if you go into cirrhosis, chronic liver diseases, cholesterol goes down. It's not being synthesized anymore. Does that make sense to you? So that one makes a little bit of sense whether it's acute or chronic. Okay, that's lipids. See how fast that went compared to bilirubin? The next is proteins. That goes all the way back to the second chunk of information. But your liver is responsible for making all of your proteins with one exception. And that exception, if you remember,
Globulins.
your gamma globulins, that's right. So liver disease is going to have something to do with your albumin and your globulin. So if you remember, it's the reverse AG ratio. And is it chronic or acute liver disease? That. Yep, it'll be chronic. Because of the half-life of albumin. It's so long that it takes a long time before it's gone. So you'll need to see chronic liver disease before you see a reverse AG ratio. The other little thing there under serum proteins is clotting factors. Because all your proteins are synthesized in the liver and all your clotting factors are proteins, if you have liver disease, you're going to have trouble with clotting. There's one little kind of side shoot, and that's prothrombin. Prothrombin is a protein synthesized in the liver. It's the thing right before thrombin, which is your clot. And it's unusual in that it requires vitamin K for itself to be synthesized. And vitamin K is a fat-soluble vitamin. Right? And fat-soluble vitamins do bile for absorption. So if you have obstruction to the flow of bile, bile's not getting through, you're not going to absorb fat, you're not going to absorb fat-soluble vitamins, you won't absorb vitamin K, you won't make prothrombin, you'll have trouble making a clot. It's usually really severe liver disease, chronic liver disease, before you get that so bad. That's proteins. Reverse AG ratio is the important one there. Enzymes. I'm pretty sure you should know this off the top of your head. So there's a lot of enzymes that go with liver disease. So if I say GGT, you're going to tell me cholestasis or hepatitis?
Cholestasis.
If I say ALT,
Metastasis.
Hepatitis.
if I say ALP, if I say AST, LDH, yeah, possibly makeup is fine, right? It's that kind of thing. So those are important for liver function. So the final isn't cumulative, but enzymes are going to come back a couple different times. So we don't get to just forget them, unfortunately. That's that. The next liver function test is ammonia. Just a couple points about ammonia. It's not a routine liver function test. I don't want you to ever order it, because when somebody's blood ammonia goes up, it's because they're slipping into a hepatic coma. So this is for really bad stuff. Right? So it's not routine, it's special order. If you suspect somebody's ammonia is high, it's a refer. It's not a care practication. I think that's all I want to say about ammonia. Then there's 3 others. We're done with liver function testing diseases. The next are some autoantibodies that you make against cell components. And there's 2 of them that have ridiculous names. One is anti-mitochondrial antibody, and the other is anti-smooth muscle antibodies. So these are autoantibodies that you make, and they kind of go with 2 liver diseases. And the anti-mitochondrial antibodies go with something called primary biliary cirrhosis. And anti-smooth muscle antibodies go for chronic active hepatitis. And I have a silly mnemonic for you. You're welcome. It doesn't make sense, but it will help you on the quiz. And it's this. The AMA is against peanut butter cookies. Why they have a thing about being against peanut butter cookies, but they are. And this is primary, so this is cheap. So if you have primary biliary cirrhosis, that patient's gonna make anti-mitochondrial antibodies. If you memorize that one, the other one you just know by default that ASM, anti-smooth muscle antibodies is for chronic hepatitis. And you got all the words that say that in your notes. And if we're going quickly, that's okay. And the last one is alpha-fetoprotein. So, alpha-fetoprotein is gonna come and get you 2 times in your life. So the first time is as a fetus, and neural tube defects, and we'll talk about it next year when we do moms and babies. Okay? Second time alpha-fetoprotein comes to get you is when you have liver cancer. And zip is my point D, so I don't know if it's your point D, so try to give you 4 bullet points down. AFP, alpha-fetoprotein levels, are used to differentially diagnose primary liver cancer, which is so cruelly called hepatoma. And hepatoma does not follow the rules for nomenclature for benign and malignant stuff. Okay? So OMA usually means, oh, benign, it's not nice, but it's not going to get you. Primary liver cancer is called hepatoma. It's horrible. It's aggressive. It's terminal. It's bad stuff. So AFP goes up in people who have hepatomas, and most of the time it's hepatoma. It can also be Mets too, but usually it's the primary, not secondary. And I think that's all I want to say about AFP. Comes for babies for neural tube defects, scores like 287. And for liver, if AFP goes up, you really think about liver. Okay. So we did all the rest of the liver function tests in 20 minutes. Bilirubin is a sticker. Truly is a sticker. Questions for me? I was going fast. I'm very sorry that your course was so.
It just wasn't, I feel like I learned medical terminology better by being submerged in the actual program rather than memorizing whatnot.
We used to teach it. Decades and decades. Now, I'm gonna put this all together into diseases of the liver. So those are all liver function tests. Okay? Now, we're talking about diseases of the liver. The first thing is some clinical features of liver disease. The first is jaundice. Well, a patient is jaundice. That's a really good indication that they have a problem with the liver. First of all, bilirubin should be greater than
50.
25 milligrams percent. I think that should be a quiz question.
Yep.
Fine, it'll be better than that. Sure it will. That's a guarantee. So then there's really big words underneath, and I apologize for it. Now I know you're not going to be listening. First one, unconjugated. So if you kind of put the pictures in your head instead of just try to listen to some words. Unconjugated
25.
hyperbilirubinemia. Anytime the bilirubin goes up, whether it's direct or indirect, the person's going to be jaundice. Don't make that mistake. So unconjugated hyperbilirubinemia. First question to you guys: would there be bilirubin in the urine? No. Unconjugated is water insoluble. So if it's unconjugated hyperbilirubinemia, which bilirubin is going to be increased, direct or indirect?
Indirect.
There's 2 kind of big things that will do this. Prehepatic, hemolytic anemia, and Gilbert's. Those are kind of your big shots for an increase in unconjugated bilirubin. Sort of in parentheses, hepatitis will do the same thing. But hepatitis will also give you an increase in direct. That is Just indirect, pre-hepatic, and Gilbert's are kind of your choices for diagnosing. If you throw a little increase in direct there, you could add hepatitis. Okay, so that's the first one. Second one is really big words, but non-cholestatic, so it means not cholestasis, conjugated hyperbilirubinemia. So find that picture in your head. It's gotta be conjugated, but it's not due to cholesterol obstruction. Okay? So that one could be Johnson, where they had trouble moving that conjugated stuff around. Would these people have bilirubin in their urine?
Yes.
Yes. Right? Conjugated water soluble. And the other one that would do this would be hepatitis. This is the direct stuff. So someone with hepatitis would have an increase in direct and indirect. And the last one is conjugated hyperbilirubinemia. That's cholestasis. And if it's conjugated, that's cholestasis. Yes for urine, bilirubin. Increase in direct. Next, how do I weigh? Where's the liver supposed to be? Open-ended questions. When you're tired, right or left?
Right.
Good job. That's right. It's on the right side. And should be about that, right? Should end just about maybe at the lower end border of the ribs. Some people say maybe 1 finger breadth below. But I wouldn't want it too much more than 1 finger breadth below. Hepatomegaly can be due to a ton of stuff. But the point is that if the liver is enlarged, there's probably something wrong with the liver. So it can be cirrhosis, it can be cholestasis, it can be malignancy, it can be hepatitis. A bunch of stuff can cause an increase in the size of the liver. Liver tenderness is a pretty good sign of liver disease, although it tends to be overdiagnosed. People are ticklish, and so when you go to palpate, people feel tenderness. Usually, it's best instead of like poking somebody's liver to see if it's tender. Most people kind of squeeze it. They try to compress it between their hands, and if it's tender, it's usually a deep-seated ache. It really aches through there. That's malignancy, hepatitis, stuff like that. It would be suspicious of liver tenderness. Portal hypertension, good sign of liver disease. Ascites is the presence of free fluid in the peritoneal cavity, which is kind of a mouthful. Ascites, acute or chronic liver disease. What would you think?
Chronic.
It has to be chronic, right? Because of the health, right? So ascites, if you see a person with ascites, you should be thinking chronic liver disease. The next one is systematic abnormalities. So much stuff. The liver is so important. Conjugates things, detoxifies things. So when it's not working, you see all sorts of systemic abnormalities. For example, anorexia, fatigue, weakness, just really nondescript, but liver dysfunction. Fever, if it's an infection, such as hepatitis, viral hepatitis, like that. Marked deterioration in health and wasted extremities, ascites that sticks out, cirrhosis, really chronic liver disease, stuff like that. Skin changes, so spider nevi. Spider nevi, if you look at somebody's, this is their nose, why should you get the right color? Use technology. Spider nevi look like this, just little kind of broken blood vessels. Spider nevi, it's a good indication that somebody has liver disease. Very often alcoholic liver disease, but not just alcoholic liver disease. Another skin change is palmar erythema, and I might wait you out on this. What other disease do you know that causes palmar erythema?
Lupus. Lupus. Lupus.
Lupus, yeah, lupus, good job. Let me go back and change some grades. Good job. A lot of people are like, we don't know, we've never heard of that before. That's right. So when you see lupus, I'm sorry, wrong thing. When you see palmar erythema, you should think of two things. You should think of systemic lupus erythematosus, and you should think of liver disease. It's liver disease, we call it liver palms and liver soles. They look identical. So you can't eyeball the difference between them. Debutant's contracture or sign of floor, sign of benediction is alcoholic cirrhosis. You can get bronze look to your skin or slate gray, that's hemochromatosis, where you don't manage your iron well and you start to store it. Excoriations from constant pruritus. If you have obstruction to the flow of bile, you have excess circulating bile salts that are extremely pruritic. And it's so itchy, people will scratch it until there's actually wounds in their skin from scratching so much. Endocrine changes, there's lots. And the pathology here is that men and women have the same hormones, just in different proportions. And when you have liver disease, you're going to start to get dominance of the wrong one. So if you're a man, you get estrogen dominance, and you get female characteristics. You start to get gynecomastia. You might get a higher voice, stuff like that. If it's a woman and she has liver disease, she gets testosterone, is getting ahead of the estrogen. She's going to get male pattern baldness, or hirsute, or a deepened hoarse voice, things like that. And it's because the liver isn't doing its job for making and conjugating those things. You just expect it. And the very last one, then we should take a break. I would like one. The very last one is hematological disturbances. The point is, you're gonna get them. So, all liver disease. First is coagulation problems. It's because those factors are proteins. If your liver can't make proteins, you can't make clotting factors. So you're gonna have trouble with coagulation. Okay. Anemia deserves a moment of our time. All people with liver disease are gonna have anemia. Just have it for different reasons. All of them. So if you have chronic infections like chronic hepatitis, you get the anemia from disease. If you have alcoholism, you get your pick. You can have B12, you can have folic acid, you can have whatever you want. If you have blood loss because you're throwing up blood because you have portal hypertension, you're going to get iron deficiency. So, point is, almost all people with liver disease are going to have some anemia, but it's multifactorial which one they get depends on the pathology. Leukopenia, thrombocytopenia, viral hepatitis, leukocytosis, alcoholic hepatitis is the big shot there. Tease those apart and they'll come back later. Really quickly, as I feel like it. If someone has viral stuff, what happens to the white count?
Down.
Yep, what cell goes up?
Lymphocytes.
If it's bacterial, what happens to the white count?
Increase.
What happens to differential?
Monocytes go up.
Neutrophils come up. Don't forget that ever. It's one of those four factoids in life you know forever. Okay, it's early, but take a goodly break. Good break. See how it works. We're gonna do some cases, even though you might not know some of the information. Don't see this. See how it goes. And there is no quiz next week. I was off by a whole week.
Oh, thank God.
Next week is Halloween. 31st. 23rd.
Oh, yeah.
Okay. Okay. So big oops, but I think we should dress up. We can all wear lab coats and be lab technicians. So neurosurgeons.
Oh, how do I remove it?
So let's, I want to try a couple cases because I know this is your long lecture day.
Exit out of it and
Hands are-
go back
oh,
to
okay.
Or start.
This is a 36-year-old gentleman. He was the brother of a guy I went to school with. And that's a long time ago, right? And let me give you the best. He went to medical doctor, patient. And this was, year. 1989. You guys, I was born. Okay, one guy was born.
I was in
Two
school.
guys, 3, 4, what's this?
I was kissing boys in kindergarten.
Yeah, by then. And I was working here. This is 1989. So for those that weren't born, the date is a little bit important here. So he went to medical doctor, and they did. So it's a little up in the air whether they did 2 or 4 tests. Let's say 4 labs. So, and I truly mean lab tests like ALT, AST, 4, not 4 like CMP and CBC and stuff like that. They did 4 labs. And he was told, the patient was told from those 4 labs that he had pancreatic cancer. So here's where the 1989 comes in. Today, 2019, if you guys were told you had pancreatic cancer and then you were needing or maybe you're doing right here, what would you do next?
Order
Well, before you change.
imaging. Imaging,
Before you
yeah.
started spending wildly. You'd probably Google it. You'd probably get some more information. Because this is a very bad diagnosis. That is not a good diagnosis. It's kind of on the next side. But in 1989, there wasn't a choice. So what he did after leaving the doctor is he went someplace. So usually a building with bricks and lots of books and stuff. He went to the library, that's right. He went to the library to look up pancreatic cancer. And he looked at it, and he read about it, and he thought, this doesn't sound like the symptoms that I'm having. So he was suspicious. And that's what he just didn't fit age or anything. So his brother, who I went to school with, DC, he said, would you look at my brother? And I said, if you're happy to, and I said, I'll take you to dinner. It's not necessary. So this is what we did. I always feel like I should say, what would you guys do? But this is what we did. You really can't go wrong with the big ones. So I did a UA, I did a CBC, I did a comprehensive metabolic panel, called it different things in those days, and he had a set rate. Those big 4, as far as lab work goes, you kind of can't go too wrong on it. So here's what came back, so one by one here. In his urine, he had a trace left. Everything else is actually pretty spread. Yeah, ask you a couple questions. What do you think about trace ketones in an adult? Something or nothing?
Was he exercising?
Something.
I'll go with maybe it's something. Okay? I wouldn't say it's probably nothing, right? But generally not too incredibly significant. But because this guy was told he had pancreatic cancer, I will put this in the back of my head as maybe that's something. So then I asked you guys, what do you remember about ketones? How do you make ketones?
Type 1.
Type 1.
Ketosis.
Ketosis. Starvation.
Or nephrotic syndrome or kidney failure.
Infamous nausea, vomiting is a good one. Hydration. Alcohol. Classic. And ketones. Children tend to put ketones in their urine at pretty little provocation. Pretty good at putting ketones out. Nausea, vomiting, stuff like that. Adults tend to have to work a little harder to put ketones out. Everything else was fine. Okay? Everything else was fine. His dipstick was fine, under the microscope was fine, swell. For his CBC, in the absence of time, I'll just tell you here, and, decreased red count. Hemoglobin crit were low, normal, mean cell volume 101. MCH 35, which I never, I'll just tell you that's increased, I don't think you force you to learn that. Differential, fine, send rate 14. So let's talk about those for a second. Let's go backwards and talk about the send rate. If you had pancreatic cancer, would you assume your send rate would be 14 or a different number?
Greater than 100? Isn't
I would think a
that?
different number, right? I would think if you have pancreatic cancer, that's kind of information. I would expect send rate to be a little bit higher than 14. That's a perfectly normal send rate. So it kind of pulls you away with that particular diagnosis. Decreased red blood cell count is anemia, right? It wasn't wildly low, but it was decreased, so it still gets to count in a fella. It's just not normal. Hemoglobin was 15, so it was still normal for our range. It was just on the low end of normal. But mean cell volume, maybe 5 questions. First of all, normal.
80 to 100.
Normal. 80 to 100 is if it's over 100, what's the cells look like?
Macro.
Macrocyte. Is 101 clinically significant?
Mm-mm.
Somewhat.
Maybe. So I'm gonna say sure. It's just barely over the range, but in combination, he's got anemia. So I'm thinking like it could be. So you guys tell me what can make those macrocytes. Folate.
Myxedema. Reticulocytosis.
Myxedema. Okay. Got all your flavors? Okay, your flavors. All right, so certainly a mean cell volume of 130. I think there's the normal range, there's a little bit of out of normal, and there's a lot out of normal. The picture that I was getting with this is this 101 is probably clinically significant, especially since it's red count. There's that. And his comprehensive metabolic panel, I need to go to a different page here. Sorry, I can't squeeze it all out. His total cholesterol is 160. I'm gonna write them down and then we can come back to general. Blood urea nitrogen was 4. Our range is 7 to 25. BUN is decreased. Is bilirubin, which is why it lives here. Bilirubin was 1.2. Our top is 1.2. I guess I'll not follow my own rules and say it's a straight jump or not.
No.
The bilirubins would be read as normal. So when we get to the rest of this picture, again, be really careful about just looking for things that are in bold or have a little plus next to it or a little minus next to it. It's read as normal, but it's significant. Is alkaline phosphatase about 1.4 times the upper limit of normal? Is GGT about 4 times the upper limit of normal? AST, ALT were fine. Amylase, that he had pancreatic cancer. His amylase was fine, high normal, fine. His iron was low at 25. The bottom was 4. Let's see if I got it. Okay, so let's start with total cholesterol. Should be less than 200, right? And it is. So So we could pat him on the back. Good job, low cholesterol. Let's not, just for a second. Blood urea nitrogen, I think I've mentioned it a million times, we haven't really talked about kidney function here. It is made in the liver, it travels to the kidney to be excreted. If the kidney's not working, it can't be excreted, and BUN goes up. If the liver's not working, it can't make BUN. So a low BUN is liver stone. It's not a classic liver function test, it's a classic kidney function test. When it's decreased, it's functioning as a liver function test. Bilirubin, it's a liver function test. It's normal, high end normal. Got a couple enzymes here. So alkaline phosphatase and gamma GT, first of all, they're too high, right? But what's more significant about those numbers?
They're not proportional.
They are not proportional. That's right. They're supposed to parallel itself for cholestasis. They're not parallel with each other. You have a disproportionate increase in GGT, which is due to
Alcohol.
Okay. Amylase was high normal, iron was low. So iron is tricky. Best thing to do is measure ferritin. Right? When in doubt, measure ferritin. Let me go back a slide and look at some commonality things here in blue. There's alcohol for your urine. There's alcohol for your immune cell volume being too high. There's alcohol for your disproportionate increase. That's what he had. He had alcoholic hepatitis. This is not from that. This is from his brother. He drinks. He cannot stop drinking. He was 36. He died at 38. Progressive liver failure. He could not stop drinking. You can say, just eat for those that have anorexia. Just stop drinking. Just stop smoking. Just exercise. You can say all those words. Patients, it's really hard to do it. It's really hard to do it.
Was that not something that was disclosed to the MD or yourself in his history?
I don't know about the MD, to tell you the truth. And I didn't get a chance to take history on this person. This was via my friend saying, could you do some labs on my brother because he's been told he has pancreatic cancer and we don't think he does. And so, from what you guys know from pancreatic cancer, what should have happened to these labs?
Amylase should have been higher.
Amylase maybe and pancreatitis maybe.
The GGT and ALD should have paralleled each other.
These guys should have gone sky high. Because cancer of the head of the pancreas is going to cause cholestasis. Cholestasis causes alkaline phosphatase to go up and GGT to go up. And if you had cholestasis, what would you think would happen to your total cholesterol?
Increase.
Go up. If you have liver disease, it's going to make this guy go down because it's not being synthesized. You could look at that and say, well, maybe that's decreased because of malignancy. I would have thought he would be more anemic at that point, but it probably has more to do with diet. So he had macrocytic anemia, probably due to alcohol, most likely due to alcohol. Chronic liver disease. His AG ratio wasn't out of normal yet, but it was trending so very close to out of normal. And chronic liver disease, probably alcoholic hepatitis. Probably. Would be the best guess. But like I say, he died 2 years later from alcohol-related disease, just couldn't stop drinking. Any questions on that one? Yeah.
Why were AST and ALT elevated for hepatitis?
Why weren't they?
Yeah.
They should be. But even though you leave work manuals and the world's open to trade check, your patients just don't get what you want them to get, and I'm so sorry. That's why doctoring is so hard. That's why you get paid big dollars. And why I would never do that to you. If I want you to pick hepatitis, I'm going to doctor my cases to make hepatitis. So I don't know why. It could be that you look at alcoholic hepatitis. Drinking, for that matter. It's a line. stop drinking, you can reverse it. If you stop before you get to cirrhosis, cirrhosis is a physical change in the architecture of your liver in terms of scarring. Much of the liver has got a really good capacity to regenerate itself. It's really easy to type stop drinking. It's really easy to say stop drinking. It's incredibly challenging. So, alcoholic hepatitis just means the effects of alcohol on those people. Anything else? Do you want to have a theme for our Halloween party?
Yes.
Should be me. Scary. We don't have to dress up, but I think when Halloween, which is a fun holiday, falls in school day, what the heck? What the heck? Ooh, is it against the rules? No, it's not against the rules. Okay. Have a good night, and I'll see you tomorrow morning.